Thank you very much for the invitation to speak today, and I only wish I could be there in person. So I'm going to speak on Philadelphia chromosome positive and Philadelphia chromosome like ALL. Here are my disclosures listed here. And here is a summary of the outline. So when we look at the outcome in Philadelphia chromosome positive ALL prior to the advent of tyrosine kinase inhibitors, we see that this was an extremely high-risk subset of ALL. And even in the last period, 1995 to 2005, only about a third of patients were alive at 7 years, and less than half, only about a third were alive without relapse, and less than half were alive. And this is despite most patients receiving very intensive chemotherapy and frequently bone marrow transplantation. The first report of the use of tyrosine kinase inhibitors in Ph-positive ALL was the Children's Oncology Group AALL 0031 study. And here you see the dramatically improved outcome compared to historical controls from the pre-tyrosine kinase inhibitor era. This slide summarizes the major studies that have been conducted to date. There are now 6 studies that have been conducted using either imatinib or dasatinib with various chemotherapy regimens, including the SFOL regimen, the COG backbone, and also a Chinese regimen, which is based on the St. Jude total 15 and total 16. And this slide tries to summarize what I feel are the lessons we've learned in Philadelphia chromosome positive ALL. First, addition of tyrosine kinase inhibitors to intensive chemotherapy improves outcomes substantially. There is some added toxicity with this, mainly infections during phases of intensive chemotherapy with the tyrosine kinase inhibitor. To date, there's no obvious difference in outcome with imatinib or dasatinib, but only one randomized trial has been performed. That trial, the CCCG ALL 2015 study, showed that dasatinib was better than imatinib, but there are some concerns that the outcome with imatinib on that trial was much less than anticipated. So I think further follow-up of that study is needed. Cranial radiotherapy can be limited to those with overt central nervous system disease. Many patients who have a good MRD response to chemotherapy plus TKI can be cured without transplantation. We also know that the newer immunotherapies are highly active in Ph-positive ALL, including both blinatumomab and CD19 CAR T cells, and that salvage of Ph-positive ALL following relapse is very possible, using either transplant or CAR T cells for those who did not receive transplant in first remission, and typically CAR T cells for those who relapse post-transplant. Now moving to Ph-like ALL. This subset was described independently by 2 groups, the COG and St. Jude group, and the Dutch Children's Oncology group in 2009. It's defined by a gene expression profile that is similar to that of Philadelphia chromosome positive ALL without BCR-ABL fusion and showing activated tyrosine kinase signaling. The gene expression profile of Ph-like ALL clusters with Ph-positive ALL and is also identified by unsupervised clustering in cohorts lacking Ph-positive cases. Deletions or mutations in IKZF1 and genes encoding transcription factors controlling B-cell differentiation are very common in both Ph-positive and Ph-like ALL. And this is a heterogeneous leukemia subtype with a diverse variety of driver mutations. And it is these underlying mutations, not the gene expression profile, that it's the critical entity for diagnosis, prognosis, and precision medicine therapies. Clinical features: the frequency increases with age. The genetic subtypes differ by age and ethnicity, and it's associated with a high initial white blood cell count, poor early response as measured by elevated end induction MRD, an increased rate of overt induction failure, and greatly increased risk of relapse and death. This slide summarizes findings in the NCI high-risk subset of Ph-like patients. And here you can see that Ph-positive ALL is about 5% in this cohort. Ph-like ALL was 22%. About half of those patients had CRLF2 rearrangements, and half of those have mutations in JAK2 or JAK1. In these older and higher risk patients, the IGH CRLF2 is more common than P2RY8 CRLF2, and about 20% have ABL class fusions involving ABL1, ABL2, CSF1R, or the platelet-derived growth factor receptor beta. And that's a similar frequency to Ph-positive ALL. About 5% have JAK2 fusions, and about 5% have truncating rearrangements of the erythropoietin receptor. And here we see how the difference, the Ph-like ALL differs in the different groups of NCI high-risk patients, NCI standard risk patients who are MRD positive at end induction, and unselected NCI standard risk patients. And one of the key differences is the rate of ABL class fusions, 4% in the NCI high risk, but only 0.2% in unselected NCI standard risk patients. We also see the differences in the ratio between the IGH CRLF2 and P2RY8 CRLF2. Now this slide shows outcome for Ph-like ALL patients who have NCI standard risk ALL. So here we can see that the event-free survival is inferior, although it's not grossly inferior at 82% versus 90%. And the overall survival is relatively similar at 93 versus almost 96%. However, it's very different in high-risk B-ALL, and here we see that patients with Ph-like ALL do much worse than those who don't have Ph-like ALL. In panel A, we see the ABL class fusions. In panel B, the JAK2 receptor, the JAK2 fusions or EPO receptor rearrangements. And in panel C, JAK mutations. So in all cases, they have a very poor outcome. And this is a recently published study from the Pontedeleño group that tried to capture data on patients who are identified to have Ph-like ALL prior to tyrosine kinase inhibitor therapy being introduced. So there were 14 groups, and they identified 122 children less than 18 years of age who had ABL class fusions. Patients were often identified due to a poor response, so this may not be a fully representative group. And of these, 85% had either platelet-derived growth factor receptor beta fusions at 52% or ABL1 fusions at 33%. And the ABL2 and CSF1 receptor fusions were much less common at 7 to 8% each. And here we look at event-free survival for this group. So the 5-year event-free survival was 59% compared to 85 to 90% for childhood ALL in general. And on the right, you see the outcome by the different fusions in terms of event-free survival. And this slide shows overall survival, which was 76% at 5 years versus about 90% for childhood ALL in general. And again, you see it arrayed by the different fusion types on the right-hand side. Now, 2/3 of patients with ABL class fusions have end induction values over 1%, minimal residual disease values over 1%. And this is typically only 3 to 5% of Philadelphia negative B-ALL cases. And here on the right-hand side, you see that those with the poor MRD response did much worse in terms of event-free survival than those with a good MRD response. So we are able to target these lesions, and there are early data anecdotal on outcomes. Now this looks at the structure of the different fusions, and in each case we see that the tyrosine kinase domain is intact and fused in frame to the 5' region of partner genes. And on the right-hand side, we see that expression of these fusions in mouse models can allow cells to grow in the absence of growth factors, just like BCR-ABL does. And then if you treat them with the proper tyrosine kinase inhibitor, dasatinib in this case, all the cases sensitive to dasatinib will die, and then the cases that don't have Abel class lesions are not affected by dasatinib. So this tells us that Abel class fusions phenocopy BCR-ABL and should be similarly responsive to targeted therapy with chemotherapy plus a tyrosine kinase inhibitor. And this also shows similar outcome for patients with JAK2 fusions or erythropoietin receptor rearrangements treated with ruxolitinib, or patients with NTRK fusions treated with crizotinib. So there are multiple anecdotal reports of responses to tyrosine kinase inhibitor therapy in PH-like ALL, generally descriptions of entering complete remission, attaining an MRD negative status, or doing well with relatively short follow-up. The Children's Oncology Group has set out to test in a structured way tyrosine kinase inhibitor therapy. So the Abel class fusions can be targeted with dasatinib or imatinib, and several of the CRLF2 rearrangements and JAK2 fusions can be targeted with ruxolitinib. So overall, about 2/3 of cases have a potentially targetable lesion. So the Children's Oncology Group has conducted 2 trials, one currently ongoing, AALL1521, testing ruxolitinib in patients with CRLF2 pathway lesions or JAK pathway lesions, and one AALL1131 testing dasatinib in patients with Abel class fusions. That the data from that trial are not yet available. And together with the SFAL group, the Children's Oncology Group is in the process of amending its current trial of Philadelphia chromosome positive ALL to the test imatinib plus chemotherapy to also include patients with PH-like ALL and Abel class fusions. Now, there have been several recent publications that I want to highlight that have showed anecdotal responses of the use of tyrosine kinase inhibitor therapy in these patients. So the first paper is from a group, French and European group, where they described 24 patients with BALL and Abel class fusions, mostly Abel1 or PDGFR beta fusions. Median age was 24 years. Only 16 of 24 were in remission at the end of induction, and all were MRD positive, 7 high-level MRD positive. And they were able to introduce tyrosine kinase inhibitors for those with newly diagnosed ALL, generally in the 2nd to 3rd month. And then for 5 identified with relapse, tyrosine kinase inhibitor was introduced with salvage therapy. And the choice of tyrosine kinase inhibitor was up to the physician. And here, looking at the newly diagnosed patients, you see a progressive improvement in response following the initiation of tyrosine kinase inhibitor therapy. 9 were able to undergo transplant, all in complete remission. 6 of 9 were MRD negative pre-transplant, and 63% of patients were alive in first remission with a median follow-up of 36 months. This is another study from the BFM groups and the Italian groups. They identified Abel class fusions by various strategies, and there were 46 identified, again, mostly Abel1 or PDGFR beta. Compared to other patients, the Abel class fusion patients were more likely to be older, have a higher white count, have a prednisone poor response, and be MRD positive at end induction. And the responses were particularly poor for patients with platelet-derived growth factor receptor beta fusions. 33 were treated without tyrosine kinase inhibitor, and 13 had a TKI added during treatment at some point, 8 at the end of induction or during induction 1B, and 4 in later phases, and 1 after transplant. About half had a transplant in first remission, 16 with no tyrosine kinase inhibitor therapy, and 9 TKI treated patients. And here you see the outcome for these patients with event-free survival shown on the left and overall survival shown on the right. The event-free survival was 49% and overall survival about 70%, with a cumulative incidence of relapse of 26% and a treatment-related mortality of 20%. There was no obvious difference in outcome based on subtype, and the patients treated with TKI tended to have worse features, and most underwent transplantation. And then this study reports the United Kingdom experience. We're partway through the UCAL 2011 study. They began screening patients without identified sentinel genomic lesions who had end induction MRD greater than 1% or induction failure. And 17 of the screened patients had an ABL class, 17% had an ABL class fusion. The mean end induction MRD in these patients was 32%. 10 had EBF1 PDGFR beta fusion, and they had a mean MRD of 53% versus 15% for others. 13 patients were identified prospectively and had imatinib added to therapy. 8 were identified retrospectively and received chemotherapy without tyrosine kinase inhibitors. And although the numbers are small and the follow-up is short, here you can see that the patients, the relapse rate in the control group was almost 75% versus no relapse in those treated with TKI. And here we see the event-free survival for is much better in the TKI patients than the patients treated without TKI. So conclusions, PH-like ALL occurs in 15 to 25% of B-lineage ALL. This incidence increases with age during childhood. Multiple sentinel genetic alterations occur that alter kinase and cytokine receptor signaling. Most common are CRLF2 JAK alterations and ABL class fusions. ABL class fusions have approximately the same frequency as Ph-positive ALL in pediatrics, and overall Ph-like ALL has approximately the same frequency as Ph-positive ALL in adults. Ph-like ALL is associated with high white count, poor response, high relapse rate, and inferior survival. Appropriate TKIs are active against Ph-like ALL in preclinical models and anecdotally in patients, and prospective clinical trials are now testing the addition of TKIs to chemotherapy. And a key question will be to define the role of transplant for patients who respond well or poorly to chemotherapy plus tyrosine kinase inhibitors. Thank you very much for your attention.